Hello everyone. So this is a new topic, HIV in pregnancy. This question is actually divided into multiple subsections, and all those subsections have been asked repeatedly. Not repeatedly. The subsections have been asked, but HIV is a common theme. So I have included HIV as a long answer here, so that if in case you find anything new, you can just add this there. Meaning, in case PPTCT comes up, you can write this from here. In case postpartum care comes up, you can write it here, like including this entirely. Or else if management comes up, diagnosis comes up, there is something to you can write about. So HIV in pregnancy, yes. Overview. HIV is a retrovirus affecting the human immune system, leading to progressive decline in immune function. This eventually leads to AIDS, acquired immunodeficiency syndrome, a condition characterized by severe immunosuppression and increased susceptibility to opportunistic infections. HIV in pregnancy is a significant concern due to its potential effects on maternal health, risk of vertical transmission to the fetus, and implications for obstetric management. So this one we are clear, self-explanatory. Now let's go into the detail of HIV in pregnancy. First one, epidemiology and transmission. So global prevalence, 25 to 30% are women who are infected with HIV, with majority being in reproductive age group. Modes of transmission, that is sexual contact, hetero or homosexual, parenteral, infected needles, transfusions, organ transplant. And in this particular case, we need to have special focus on vertical transmission, mother to child transmission, MTCT. It can occur transplacentally, perinatally, that is during labor, or postnatally during breastfeeding. Risk of MTCT without intervention is 15 to 40%. Risk is reduced to 1 to 2% with antiretroviral therapy and elective cesarean section. Male to female transmission is twice as common as female to male transmission. So male to female is more common. So that is coming under transmission, not this. Yeah. So pathophysiology. So HIV targets CD4 plus cells, CD4 cells, leading to progressive immune damage, and acute phase is 3 to 6 weeks. If there is you can see flu-like symptoms, and latent phase about 10 years, gradual decline of immune function. So that is way into the future, and CD4 is the main key marker which shows severe immunosuppression with opportunistic infection. So AIDS is, so CD4 is the key indicator of AIDS being present, and also the viral load and all of that we will be going through it in the diagnosis section. Coming to the effects of HIV in pregnancy, pregnancy itself does not worsen HIV progression. Increased risk of miscarriage, preterm labor, intrauterine growth rate restriction, preeclampsia, and perinatal mortality is these things are more common. Coming to neonatal effects, low birth weight and failure to thrive, increased risk of neonatal infections, neurodevelopmental delays in some cases. So these are the effects of neonatal effects of HIV: low birth weight, neonatal infection, neurodevelopmental delays. Coming to the investigations, there is screening and disease progression monitoring. Screening, we do ELISA, 99.5% sensitive but requires confirmation, and then there is Western blot or immunofluorescence assay, IFA, detects specific viral proteins, and then HIV RNA PCR is most specific. ELISA, Western blot or immunofluorescence assay, HIV RNA PCR. Disease progression monitoring, there is CD4 count less than 200 per mm cube, diagnostic of AIDS. Viral load, high maternal viral load is associated with increased risk of transmission, and HIV genotyping to check for resistance mutations. So these are some key investigations that we can do. Finally, coming to the management, there is antenatal care, intrapartum and postpartum, and within postpartum specifically we also look at prevention of, not within postpartum, it also includes pregnancy, prevention of mother to child transmission, and finally contraception and future pregnancies. Coming to antenatal care, voluntary counseling and testing at antenatal visits. voluntary counseling and testing, screening for coexisting STIs and opportunistic infections. So, other STIs and opportunistic infections. ART. So, now some drugs. Yes, these are have some kind of weird code names, but still we will try to make it easier. WHO recommends ART initiation if CD4 count less than 350 mm³ per cells per mm³ or viral RNA greater than 50k copies per ml. And there is first line, second line. First line is zidovudin, lamivudin, tenofovir. Zidovudin, lamivudin, tenofovir. Yeah, repeating it over and over again should make it stick in more. This one into your head. Second line ART, efavirenz, emtricitabine, lopinavir, ritonavir. Efavirenz, emtricitabine, lopinavir / ritonavir. So, first line and second line. So, this is the only section which you might forget during the exam. Next, coming to ART, and also there are some drugs lower down too. ART should be continuous throughout pregnancy and labor and postpartum. Elective cesarean section at 38 weeks if viral load greater than 1000 copies per ml. So, that is about antenatal care. Next, coming to intrapartum. During labor, what do we do? Zidovudin IV infusion during labor, avoid prolonged rupture of membranes. Cesarean section indications, we have seen it here already. Viral load greater than 1 k per ml, failed ART therapy, coexisting obstetric complications, and vaginal delivery consideration, possibly viral load less than 50 copies per ml. So, it should be so low, only then you can consider vaginal delivery. Avoid instrumental delivery, forceps vacuum, avoid episiotomy unless essential. So, we do not want the child to get exposed to the virus, that is why we are taking so many measures to avoid the vaginal delivery and go with the cesarean section instead. Then coming to postpartum care. So, in case of mother, so there is for mother there is one, and neonatal management there is other, and breastfeeding consideration. So, these are the 3 key points we need to have in mind before we write the postpartum section. So, continue HAART therapy, heart therapy, highly active ART. Close follow up with CD4 count and viral load monitoring. Neonatal management, zidovudin syrup. So, this is the first syrup here. We rarely see syrup in medicine in entire final year, and this is one of the few places where syrup is used. Zidovudin syrup for 6 weeks, and HIV testing done at 6 weeks, 12 weeks, 18 months. 6 weeks, 12 weeks, 18 months HIV testing, and exclusive feeding formula feeding to prevent postnatal transmission via breast milk. But breastfeeding considerations. WHO recommends exclusive breastfeeding with ART intervention for 6 months in resource limited settings. So, this is specific condition where there is resource limited setting. You could do exclusive breastfeeding with ART intervention for 6 months. Avoid mixed feeding as it increases the risk of HIV transmission. This is something we need to check out because this came to my mind just now. Why mixed feeding avoided? Mixed feeding breast milk plus formula feed increase strongly discouraged. Why? It increases the risk of transmission. How? Formula feed animal milk or solid food can increase inflammation and micro injuries in the infant's immature gut lining. These micro injuries increase mucosal permeability. Yeah, increasing the risk of transmission from the breast milk into the bloodstream via the gut. Increased viral load in breast milk. So, mixed feeding associated with suboptimal breastfeeding, which can lead to fluctuation in maternal breast milk production. This fluctuation can cause milk stasis, leading to breast engorgement, mastitis and cracked nipples, all of which increase the risk of viral load in breast milk. Low levels of protective maternal antibodies. So, exclusive breastfeeding provides continuous maternal antibodies and immune factors. Mixed one, infant is more vulnerable to infection and GI infection, auto and immune activation, Mixed feeding increases the risk of diarrheal infection due to contamination from non-breast milk feeds. Infection trigger inflammation, immune activation, which lead to the increases the number of CD4 T cells in the gut that can, which are the substrates for HIV. So, HIV, we do not want interaction between the HIV and the CD4 cells, and that is one of the points here which they have mentioned. So, let us copy this. This is a very interesting answer, and let us paste it here, because I always wondered but never bothered to search it. HIV in pregnancy. I will share the answer. Coming to prevention of mother to child, early transmission, early ART intervention for all HIV positive mothers, elective C-section at 38 weeks if viral load greater than 1 K per ml, zidovudin prophylaxis for neonates, avoid breastfeeding unless resource limited settings where ART intervention is available, post exposure prophylaxis for newborns within 4 hours of birth, within 4 hours. And finally, coming to contraception and future pregnancies, barrier methods to prevent transmission, copper IUD, LNG IUS are safe, and combined oral contraceptives are avoided due to drug interaction with ART, and sterilization can be considered if family is complete. And with this, we come to the end of the discussion on HIV in pregnancy. So, this was a very interesting section, especially the reasoning behind why the mixed feeding is not good. And with this, we come to the end of the video. In case you like this particular video, you can like it. In case you would like to watch more of such videos, you can subscribe. And in case you have anything to discuss, you can do it in the comments. Bye.